presenter is one of my dear friends, Alia Azmat, who I know both professionally and personally. She's a doctoral candidate in counseling psychology at Purdue University. She's interested in identity, culture, mental, and reproductive health. In addition to her research and clinical work, she's the manager of research project for women's heart, women and girls. Welcome, Alia. We're happy to have you. It's all yours.
That's the one I was talking about, heart, women and girls.
Hello, can y'all hear me? Is this
Not loud enough.
not loud enough? There, how about this?
This is better.
Okay, great, thank you so much. Assalamu alaikum everyone, good morning. It's really great to be here and it's great to be in Phoenix again. I actually went to undergrad here and I feel very connected to this place. And so I'm really excited that I get to present on some of my work. As Suchi, oh, you did that, okay. As Suchi mentioned, my name is Alia Azmat, and the title of my talk is Girls Should Be Seen, Not Heard, Self-Silencing and Self-Objectification in American Muslim Women. And so I am just going to get started. So I want to start just by sharing a few words of gratitude and sort of a little bit of storytelling. The data that I'm going to be presenting comes from, I think, a deep trust in the women that shared their experiences with me. Even though this was a quantitative study, there was an element of some qual, sort of like an open-ended question, but also more than that, a real trust in me that I was going to do something important with this data, and that to me right now is that I'm sharing it with you all and sort of sharing this story. I should have done that earlier. Around what I think that they're saying and how these constructs have sort of shown up in various Muslim American women's lives. And so self-silencing is this idea that you have to diminish your own needs for the needs of other, leading to a loss of self or a sense of grief around your own identity. And what I looked at was the contribution of self-silencing to depression. And self-objectification is this idea that you're sort of policing your own body. You know that other people are watching your body. And so when I heard about this construct and this theory, I used to wear hijab and it just fit for me. It sort of gave me language around what I felt like I was doing, what I felt like my peers were doing, my other Muslim women were doing, older family members. And so that is sort of the story around why I selected these two constructs and how they contribute to poor mental health outcomes. And so again, I'm just really indebted to the people who participated in my study, people who shared my study, who are in this room, and people who have sort of given me the strength to do this and make meaning of my own voice. So I also want to start by sharing a little bit about sort of positionality and something that's come up for me as I've done this work, which is who gets to tell the story of this data, who is this story for, what assumptions are we making from the data? So as you look at the work and as you look at sort of what's come out of the work, I want you to think about what that means for you and how you're interpreting the data as well. And so I have to be upfront and honest around where I'm coming from as well, and that is how does my position, I've shared a little bit about being a Pakistani American Muslim woman who was born in the United States, impacting my engagement and her interpretation of this data. So I think that's something to keep in mind and something that I want to model for you all throughout this presentation. Okay, I'm going to skip this because I don't think there's time. So, but there's a quote by Faria Rosen around this idea that brown people are policed and surveilled, and that sort of is an internalization that we do in terms of our own oppression. And so I thought this was relevant, but I'm going to keep going because I only have 15 minutes. So just a brief literature review. Why am I studying depression? Depression is higher, 50% higher in women than men. Muslim women have a lot of different intersecting identities and experiences, and that's important to acknowledge. And the intersections of those look very different based on different racial identities or orientations. And then self-silencing depression has been shown to exist in white, Asian, and Hispanic women, some Black women, and some Turkish women. And so there's some literature around how perhaps like the pride in racial identity and the pride in sort of a cultural identity that is more interdependent with Black and Turkish women may be serving as a buffer. And so I wanted to see what was going to happen with my sample. And then body shame and body surveillance have been related to the internalization of cultural standards of beauty and objectification in American Muslim women, and that's a study that was done with Muslim women. So the framework that I'm using is something that's titled Femininity Ideology, which is basically that women internalize ideas of what it means to be a, quote, good woman. And so the way that I frame this is, again, through self-silencing and self-objectification, but Dr. Bunmi, or Dr. Oji up there, she has also done some research around this with Black Muslim women. And so what she says is that there are notions of good Muslim womanhood that are shaped by gender socialization. And that socialization is shaped by both religious and cultural teachings, as well as structural concerns like racism, like sexism, like Islamophobia, all of which are playing out in the bodies of us as a community of Muslim women. So basically my research questions were to highlight the nuance in Muslim women's experiences around this topic, to explore what degree both objectified body consciousness, silencing the self, and religious commitment contribute to women's reports of depression, and then to think critically about what clinical and community-based interventions could look like. So the methods that I used were obviously the silencing of the self scale. There's 4 subscales there: the divided self, carousel, sacrifice, externalized self-perception, and then silencing the self. Objectified body consciousness, which has 2 subscales that I use: body shame and body surveillance. So shame is tapping more into the affective element of objectified experiences, and then body surveillance is more around the thoughts and feelings of, like, I think about my body, or when I'm not a certain weight, I feel a certain way. And then religious commitment, and then my DV was obviously around depression. The method that I used was a linear regression. It's pretty simple, but it's pretty compelling data that's going to come up. So, demographics analysis. So my table is maybe not big enough, but there were actually over 250 women that started my survey, but 147 are the ones that completed the survey all the way through. So the data that you're looking at is a very clean sort of sense of about 150 women and their experiences here. The age range was 18 to 66, about 50% were Asian, followed by 15% Black, and then other and white. And one of the things that I also learned through this project was some of my demographics were not the best. I did not include MENA. I missed some, I know, Elise.
No, I'm saying
so, I missed some of the Southeast Asian American experience. I didn't call it out as directly, and so that's things that I'm thinking about moving forward. Nonetheless, again, in terms of positionality, I think it's important to think about generational status. About 71% were born in the United States, 88% were heterosexual. And this group was a pretty highly educated group, with almost 60% completing their a 4-year degree or a master's degree. And then in terms of marital status and in terms of hijab status, there were the group was about split. So 55% single and about 55% who observed hijab. And the way that was examined was, I had asked, do you consider yourself hijabi? So a self-report, and then also what type of style of hijab do you wear and how frequently? Because that's been used in the past. So my results, what I really want to call attention to is this, because this was the result of my regression. So the R-square shows, oh my God, why does that keep happening? About 48% of what is contributing to depression can be related to religious commitment, and then STSS and OBC. And the reason that I broke it down here is just so that you all have a more sort of nuanced understanding of some of the numbers. But what this is showing, the p-value is sort of significant, saying that variables related to femininity ideology, that self-silence. So sorry. better? Yeah. Okay. 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 I apologize. Okay. Thank you for that. And so when we look at some of the more specific subscales, they're also significant around religious commitment, around the subscale of externalized self-perception, which is sort of speaking to like, I want to be what others want me to be instead of creating their woman's own self-identity. Kara's self-sacrifice, that one was not significant, but when it was pulled together it was. And then shame and surveillance. And I think what's really interesting for me, particularly as a brown or Pakistani Muslim woman, is this element of shame coming up in contributing to depression, right? So taken together, both STSS and objectified body consciousness, self-silencing and self-objectification predicted depression. But when you look specifically into shame and surveillance, women are surveilling themselves, but the shame part of that subscale was even stronger. So there's a very important, I think, clinical implication to that, which is working through shame around all the different parts of that Muslim woman experience, right? Of the body piece, of the being Muslim piece, of the racial identity piece. And so that is what I want to sort of highlight here. And then I tested pretty basic t-tests around if there were any differences on the prediction of self-silencing and self-objectification between marital status, between if people wore hijab or not, between race, sexual orientation, and if someone was born in the United States, and there were no differences. So taken collectively, I think this tells a pretty compelling story around how women are internalizing ideas of what it means to be a good Muslim woman, and how they are making themselves smaller. They are spending a lot of cognitive energy based on objectification theory, thinking about what they look like, how they're taking up space, who they're around, thinking about when they should talk, when they shouldn't talk, who they should speak to, how much they should speak, and how that has real implications around how they exist in this community and outside of the larger Muslim community. So in addition to this, the quant stuff, there was this element of if you strongly agree or agreed to this question of do you feel like you're not living up to certain expectations, then you had to list 3 expectations that you do not feel like you live up to. And looking at that data, I sort of coded and looked at it and categorized it in 3 different ways. And so here, there's a big theme around weight, a big theme around education and career, a big theme around relationships, spirituality, and domestic chores. And so these are my participants' voices. These are the things, oh shoot, that's fast. These are the things that they're saying, right? Maintaining a healthy weight. Faith standards, I don't feel like I live up to those. Housekeeping, I don't feel like I live up to those. Participating in family events, which are all, I would say, appropriate and normative things to be concerned about, but to know now, in addition to the quant data, that this is contributing to distress in this population, I think is really important to consider. Okay, so discussion, basically internalized notions of self-silencing and self-objectification, what it means to be a good Muslim woman, are playing a significant role in the experience of depression, meeting expectations around weight, relationships, spirituality, and domestic tasks and career, and again, back to Dr. Bunmi's, some of her implications as well, that this identity is contested and has different sorts of consequences. Moving forward, I think I would just like to pitch that there needs to be more pluralistic notions of Muslim womanhood, supporting diversity and ensuring everyone feels seen and heard in the Muslim community, and that as Muslim women that we need to be also mindful about some of the assumptions that we make about other women and how we are behaving around each other. And so some of the research that I think that I would like to continue is around internalized sexism and what that means, devaluing a woman's worth, and how sometimes that plays out between women, around competition between women, around mistrust of different women, and also some womanist identity development. I'm going to be obviously more mindful about my demographic questionnaire, acknowledging the role of religious commitment as both a risk and a protective factor, particularly in this community. It's not easy. It's not one or the other. Sometimes it's both, and it is, again, dependent on context and is contested. Community-wise, I'd encourage all of us to think about the impact of not feeling seen and heard. If this is an experience that speaks to you, I think this is something to think about, that it's not just you, and that we are struggling together perhaps in this story. Reflecting and rewriting on these narratives of good Muslim womanhood, and then checking and challenging assumptions towards women's bodies and voices. And what that means, and what that means for me in particular, has been a lot around the self-doubt, self-censorship, not calling out when people are being body shaming in my family, calling out when someone says, like, right, I'm just an angry Western feminist, like, what is that really about? What's happening there? So, I am a deeply spiritual person, but what's happening? What is this challenging in some way? Okay, great, that's something to think about. And so we are constantly being evaluated in that way. Limitations, 50% Asian. I think that also speaks to who I am and my reach right now, and that is something that I'm going to be actively working to change for my dissertation project. It is heterosexually skewed. Measuring religious commitment is difficult, and I wasn't able to.
So thank you for that research. It's so incredibly important. Moving on, we're getting on to our next presenter. And the next presentation is the role of social support in seeking counseling from Imams versus peer support groups in Muslim women. We have a presenter, Kashmala Qasim. She is a PhD student at York University pursuing social psychology. She also had completed Talimul Quran diploma course from Al Huda University and has been a lecturer at the Islamic Online University and has received level 1 pastoral counseling training from the University of Toronto. Welcome, we're proud to have you.
Assalamu alaikum everyone. I hope you can hear me. Is it with the mic? Okay, awesome. So my name is Kashmala, and today I'll be talking about just some of the studies and findings that I have found thus far in my PhD work. This is not my dissertation work, but I am hoping that some of these findings will be used for that.
She's at York University.
With a true story, a little bit of a sad but true story. So a friend of mine had posted this about her mom's experience with depression. She posted this on Facebook in 2017, 2018 rather, and her mother was told by several imams within the Toronto community, I'm from Toronto, Canada, that it was evil eye. Sadly, some of the imams took a role that they were not qualified for, and sadly we believed them blindly. Her mother did attempt suicide, and she did pass away from some of those injuries later that year. So this story essentially was the backdrop, the framework, the motivation even for some of the work that I'm presenting today on the role of imam counselors and how we can perhaps insert other forms of informal care and look more towards women-based peer support groups. So of course, 5 decades of research has shown us that religious leaders are the first line of support for many ethnic minority groups. This is not just for Muslims, it's evident in Christian and Jewish communities as well. However, little is known about the mental health literacy of imams within a mosque setting. So I proposed a framework, and this will hopefully result in a dissertation, inshallah, at the end of this 6-year PhD, that I'm first looking at the role of imams in providing counseling. I'm presenting the studies on the findings from this study first. I will then be talking a little bit about my proposal for conducting a needs assessment and a peer support group. And I'll mention a little bit about the design and what I'm hoping to do with these women, and I would love your feedback for that at the end. So the objective for the role of Imam Counselor Study was to understand in what capacity Imams are currently providing mental health support within the Toronto area. Imams, as we know, have several different roles. They are heavily burdened. Of course, they have to lead prayers, deliver sermons, do all of our nikah and marriage ceremonies, and they're also considered a spiritual care provider. Within my study, we interviewed 9 Imams across the Greater Toronto area. Their ages were between 30 and 65. In terms of ethnicity, I was running into the same problems as Alia and as our first speaker, that there were 8 South Asian and 1 North African. And the majority of mosques that I was able to get a hold of were Sunni mosques. We did end up contacting 1 Shia mosque and 1 Ahmadiyya mosque as well, but generally a pretty homogeneous sample. Okay, so after conducting these interviews, most of the interviews lasted from between 30 and 45 minutes. There were, of course, audio recorded, and they were transcribed by my lovely RA here, Shaquille. I want to give a round of applause to him, that he did a lot of the work for this study. I feel like we should really, I don't know what it is in the States, but in Canada we don't pay our RAs. I don't know if you guys pay your research assistants. We're not allowed to pay them, which is, I would love to just give you a gift card or something. And after all this, yes, exactly, so I can do that. So after doing all this transcription, I ran my analysis. It was an inductive approach, and more specifically, it was a grounded theory analysis, in which you are using the data and the voices of the participants, so in this case the Imams, to really guide your theoretical framework as well as your future studies. So you're not inserting, or trying not to insert, any of your preconceived notions. I do want to mention my own reflexivity, as the first speaker presented as well, that we, especially in qualitative studies, you have to position yourself and talk about your assumptions. So I'm a Muslim woman, I go to a mosque, I have contacts with Imams, I look up to Imams, and I do have certain assumptions about Imams and sort of seeing the male figure as the lead of the mosque and women coming to them for help. So these are my own biases and assumptions going into this. So myself and my research assistant, we came up with 25 codes. We combined them into 10 subcategories, and then we derived 3 main categories from that. So I'll present those 3 to you today. The first category was desperation and diagnosis. So when we asked the Imams, why do people come to you? Why are these congregants coming to you instead of going to a family doctor, instead of going to a counselor? Thankfully, we have OHIP in Toronto, so some of these services, many of them are covered, so why not just go to them? Across the board, the theme was that many people come pre-diagnosed. So I have evil eye, there's a jinn-related issue, they already come with this pre-diagnosis and they just want to be validated, they just want to be heard. The other reason that was mentioned by almost all the Imams was desperation. Because of the desperation and need for this kind of guidance, they felt like they had no choice. A couple of the Imams also mentioned accessibility, that they have office hours, they're literally just there in their office after like Zohar Salah or after Isha. The door is open, so people just can come in and essentially get like an hour-long free counseling session. So that is one reason as well. The other main theme that came up was resources. So when we asked the Imams, do you have enough resources for mental health, training, counseling? Like, are you just like going on Google and just searching up like what's schizophrenia, what's bipolar? And that it was supposed to be like a comic relief type of question, but it actually ended up being true. The Imam said like, yes, I'm literally going on Google and just like someone comes into me, a female comes and says, I have an anxiety disorder, and they're like, okay, just sister, 1 second, I'm just typing up anxiety disorder. And it may seem funny, of course, but I just felt so bad for the majority of my participants that they had absolutely no training or knowledge, and they were trying to get that training. But as one Imam mentioned, that it was a $1 billion question, no resources, no support, no training. I only do this sort of work because there's a need for it, and there's just nowhere else for these people to go. And the final category that came up from my analysis was the visibility of mental health effort, that although these Imams were putting in several hours every single week counseling, or so-called counseling people, advising individuals, when we asked them that do you feel that your efforts are being noticed, what's happening, one Imam mentioned it really well, that if you build a gym, 50 kids will come and play basketball, the masjid or the mosque looks busy. If you spend that same money over 4 years with a mental health worker, what are you going to say? My community is less crazy now. There's no tangible outcome. And that's so true. These Imams have no like quantifiable data. They don't have a report. They're not showing to the board members that, okay, these are the number of people I saw this week. These are the demographics. So I was like, maybe I should just create like a report for them. That could be my dissertation if that counts. So visibility of effort was little to none. So just to summarize the main findings before moving on to the proposal part of my dissertation, Imams felt overall a dire need for mental health services in the Toronto Muslim community. Imams within our sample reported not being qualified. I think there was one Imam who mentioned that he took Psych 101 in undergrad, like one psych course. And so there is that discrepancy. Imams, all of them, across the board, Sunni, Shia, Ahmadiyya, all the Imams that we talked to were super eager in enrolling in a program. They were like, Sister Kashmala, if you do some sort of training program, there are things happening in the States, I don't know about Toronto. They were really eager to do that as well. And personally and financially, they were experiencing a lot of personal demands on their time, so it was really hard for them to be empathetic to the people coming into their office. So moving from these discussions, just a quick note of limitations, that of course this was a very small sample size. It was a qualitative study. Despite that, we only had 9 Imams present. It was a homogeneous ethnic samples. The majority were Sunni mosques. And when we did go sometimes into these interviews, or at least when I had gone by myself a few times, the board members sort of knew we were coming, and some of the other employees of the mosque knew we were coming, so there may have been motives to present themselves in a more positive light. So that is one limitation, as always. So now moving away from Imam counseling and Imam support, since we have some of this data now, and this also is similar to the other literature as well, that Imams are heavily burdened and they don't have formal training as of yet, but they are looking forward and working towards it. Another method of informal support is peer counseling support or peer support. And peers are essentially individuals that live in the community and they have recovered from a mental illness or some sort of a life situation, so they've undergone the recovery process. And peer support in the literature has been shown to reduce symptoms of depression without any sort of formal counseling. So this still comes under informal care. Just like Imam counselors are under informal care, peer support is another channel of that as well. So for my proposal, I'm hoping to inshallah work with Khalil Center in Toronto. They just opened up like a month ago. So we're hoping to recruit 10 Muslim women, 18 plus, who have been divorced recently, or we haven't really figured out what the timeline will be, but the target population is now on divorced women. We're seeing a huge lack of support, and perhaps in literature. I have to look into literature a bit more, especially within the Canadian population. And the majority of Imams also from their previous study mentioned that 65 to 75% of the women, of the people that are coming to us are women with marriage issues, in-laws, of course, divorce issues, right? All these things that we're all experiencing. So the majority of people coming to these male Imam counselors are women. So why not just empower other Muslim women to help other Muslim women? So that's sort of the backdrop for this. The groups will be led with a peer facilitator. She is a licensed psychotherapist, and she has also undergone the same experiences as a group. I will be there in a research capacity. I'm not a counselor. We're hoping to do 2 groups per month and run about 8 groups in total. And each peer support group will be an hour and a half in length. And our proposed model, if my supervisor, inshallah, approves this, we will hope to conduct a discussion every week on a different topic related to divorce. So divorce and self-care, divorce and finances, childcare, different elements of relating to a woman's experience after divorce. We will then have a few minutes to do a mindfulness or breathing exercise. We will then have 10 to 15 minutes for reciting the Quran or listening to it, and then a reflection period. And finally, at the end, we will debrief the group and have final thoughts and work on next week's topic. And this will be a participatory model, so the women will tell us what they want to talk about for the next week. So I'm not making up the topics. They've undergone this experience, so I want to give them the voice. The proposed design, it is going to be a pre-post comparison. This is a mixed methods study, inshallah, so both quantitative and qualitative data will be collected. We're going to try and collect data on anxiety, depression, stress, and religiosity should also be in there at weeks 1, 4, and 8, and I will be doing the qualitative data analysis. Okay, so that is essentially the end of my presentation. I know it just ends off very abruptly, but I'm literally at this stage with my PhD. I'm at the proposal stage, and I do want to just give a shout out to the first speaker, Alia. I was taking notes during her presentation. It was so good. It was just, I have not seen, there's not that many Muslim women doing a PhD in our university. I don't know if it's a Toronto thing or if it's just our university, so just, it was amazing. So jazakallah for that as well. I want to acknowledge my supervisor, Dr. Michaela Hinia, who is super into faith-based research and culture-based research. Dr. Fuman, who is one of my advisors on my PhD committee, Shakil Mirza, my research assistant, and all the Imams and the mosques, and hopefully the women who will agree to participate in this study. Thank you so much.
Our next presentation is HPV screening among Arab American women. And the speaker, again, a very dear friend of mine, Lamia Shawaheen. Dr. Shawaheen is an assistant professor in the Division of Psychology and Counseling at Governor State University. Dr. Shawaheen completed her pre- and postdoctoral clinical training in APA accredited training programs at VA Hospital and completed her doctoral training in counseling psychology at Purdue University. Her research centers on exploring risk and resilient factors among ethnic and religious minority individuals within the United States. Please welcome Dr. Shawaheen to the stage.
Okay, so everyone else started with a story, so I'll start with a story too. I wasn't planning on it, but most of my research has centered broadly on Muslims, and I tried to look at the different ethnic groups that make up the Muslim population. With this project, I took a little bit of a deviation and wanted to focus exclusively on Arab American women. This particular issue is really significant to me personally. I experienced a death in my family related to cervical cancer, and for those of you that have like medical training and medical background, that is a cancer that no one should die from. Early detection makes it very, very preventable and treatable. But some of the cultural sorts of barriers to actually getting screened and getting vaccines and things like that make it a bigger problem in our community than it should be anywhere. And so this project is what we have in our communities. All right, so what the research shows, and in the US, we know that when we sample from mosques that we're not getting a full, clear picture of the community there. And so these problems occur in terms of actually collecting the data and moving forward with analysis. What we do know from the data that does exist is that Arab American cervical cancer screening rates are lower than their white counterparts and are comparable to other ethnic minority populations. So what I'm doing right now with this project, and again, this is kind of like a proposed research. It's supported by the Center for Arab American Philanthropy. So what I'm doing is I'm trying to integrate a few different theories of healthcare to better understand this phenomenon in the community. So many of you are probably familiar with the health belief model. This is a social psychology concept that posits that individuals will take health-related action under 3 conditions. So the first condition is they need to be able to feel that a negative condition can be avoided, right? So you have to have the belief that, okay, if I get this screening, it will prevent cancer, or it will prevent getting HPV, for example. They have to have a positive expectation that by taking the recommended action, they'll avoid the negative health condition, and they have to believe that they can successfully take that recommended health condition, right? And just looking at these 3 factors, there are already a lot of cultural expectations that play into having these 3 beliefs. So, for example, for individuals who have a more fatalistic belief system, they may not believe that conditions can be avoided. They may believe that if they get cancer or something like that, it's a punishment from God, or it's a test, or things like that, which are still valid beliefs, but they can sometimes be in conflict with what needs to happen in order to get people the care that they need to get better. Similarly, a lot of folks, especially the younger women that I've been talking about this project, they don't want to go to the doctor because they're still on their parents' health insurance. Well, I don't want my parents to know that I'm going to a gynecologist, and so on and so forth. So these are some of the issues that we run into in our community. Oops. Oh, come on. All right. Here we go. Okay. So this is just a diagram. So for example, folks need to believe all of these things and actually to get the gears moving and going to a doctor and getting some of their gynecological needs, including screening, taken care of. And at the same time, we don't know much about Arab American women's beliefs around these issues because of the lack of data. So, from the data that we do have, and the future Dr. Azmat did some research on this area as well, but from the data that we do have about Arab American women, some of the risk factors include perceived lack of female clinicians, so difficulties finding female gynecologists who can work with them, concerns over modesty. Access-related issues are a problem, but even when adjusting for access-related issues, we still see lower rates of screening in this population. And then a lack of knowledge regarding cervical cancer and its prevention. Some protective factors which haven't really been examined in the research are acculturation. Higher educational attainment is actually sometimes mixed in the research. It doesn't necessarily protect women from some of the factors that affect women with lower educational attainment. Social norms are protective factors, so what the research does show us is that women who have peers who are going and getting cervical cancer screenings and getting the HPV vaccine are more likely to be going and getting those treatments for themselves as well. And then finally, and this is a tough one, married status is protective. So when women are married, it's more acceptable for them to be going to the gynecologist. But one of the things that has been found in the research is that folks don't seem to always understand that HPV can be contracted in other ways as well, and that it's not necessarily only contracted through sexual interaction. And so that can be also a problem. Okay. So another theory that I'm applying to understanding this phenomenon better is Myers' theory of minority health. And so in Myers' theory, essentially, this diagram sort of shows that by pathways of psychosocial adversity, psychological processes, and psychological resources, women make the decision whether or not to actually get screened and get vaccinated for various health issues. Myers' model can be understood as better taking a look at just the pathways by which people make decisions. So some of the psychosocial adversities that are unique to Muslim women, like Alia was talking about in her presentation, is the overall stress that Muslim women are under, as well as gender-based discrimination that uniquely impacts Arab American Muslim women in particular for this study. One of the factors that is protective is stress appraisal, and that has not been studied in the literature at all, of looking at how do Muslim women make sense of the stress that they're experiencing and how does that impact their decisions about their healthcare choices. And then finally, psychosocial resources, looking at community support, looking at acculturative factors and things like that is not really examined in the research at all, just because of how little research there is on this topic. So some of the limitations that are that we're finding is that most of the research that has been done focuses primarily on underserved communities in Dearborn, Michigan, so we don't really get a clear picture of other sociodemographic communities, looking at higher income Arab Muslim women, looking at Muslim Arab women who are around the country. There's a limited focus on protective factors. Most of the research looks at culture as a barrier, and it doesn't really explore the other side of that, which is where that social support piece comes in. And there's also limited focus on single Arab Muslim women. So most of the research focuses on women who are already married, where it's socially acceptable for them to be going and getting this care. And then finally, there's a missing piece in here from the physicians who are working with this population and other members of the healthcare team. What are they experiencing on their end when they're trying to talk to their patients about getting the HPV vaccine or getting cervical cancer screenings for their children? So some future directions and where I hope to go with this research is to examine cultural facilitators or culturally relevant messaging that may encourage routine cervical cancer screening, even in unmarried young women. What can we do to support women who are, for example, still on their parents' health care and don't want a bill going to the house or don't want it to show up on their insurance that they're going to see a doctor? What can we do for those women to ensure that they are protected in the future? Another future direction is to look at more economically diverse Arab American Muslim women, and then to also explore acculturative factors in a multifaceted way. So most of the literature looks at acculturation simply as how long have you been in the US? Do you speak English? Are you first or second generation immigrant? It doesn't look at some of the more nuanced characteristics like how easily do you move or code switch between two cultures? How easily are you able to navigate the dominant culture while still retaining your cultural identity? Those factors have been shown in other ethnic minority populations to be really critical to health. And then finally, what I hope to come from this research is to develop culturally relevant interventions and programs to ultimately increase cervical cancer screening rates in this population and ultimately contribute to the overall well-being, hopefully, of the population. That's all.
The first one, and it's open to the panel, is one of the reasons that the sisters go to imams for mental health issues. Is it the fear of going to non-Muslim practitioners who may tell them that this illness is due to Islam?
Didn't get the question.
Did she say it's due to Islam?
Yeah, that's what she said.
I mean, I've worked in clinical settings with Muslim women, and I mean, I've honestly had a mixed experience. Like, I've had people who have gotten me as a clinician and didn't want to work with me because they were worried that I would judge some of the issues that they were bringing to the table as well. So I feel like it probably goes both ways. In my dissertation, I actually found that Muslim women do not feel supported by their religious leaders in the sample that I had collected. I tested for religious leader support, and do Muslim women in the mosque communities feel supported enough by their religious leaders to go to them and talk to them about these issues? And I actually found that they felt much less supported than their male counterparts. And also that Muslim women who don't wear the veil feel even less supported by their religious communities, both other people in the community who are practicing as well as their leaders. So it's a really challenging, I think, and multifaceted issue.
Yeah, I second that as well. I just a very recent needs assessment that we did with women. So the imams on their side of on the spectrum, they're just like trying their best. It's like whatever that best is, whether it's going on Google and searching up mental illness. But what the women are saying is exactly what you said, that I feel like I'm being judged. I'm just told read these ayahs or read these du'as. So there is like something is missing. The men are trying and the women are like, no, like this is like, it's just not working for me. There's a lot of advice giving, not as much validation or empathy. Sometimes these women are coming in telling their entire life story and you have a 10-minute session with the imam, right? So there's of course going to be discrepancies there. The women that I spoke to specifically within the mosque-going community, they actually just a fear of going to a non-Muslim mental health practitioner because they want that integrated approach and they think that the imams are counselors. And there is, I'm not going to mention of course any mosques, but there are several mosques, and on the door of the imam's office it says counselor. So it's like, and most people don't know what it takes to become a counselor. You could go to Medina University, study 10 years, you will not be a counselor. You'll be an excellent scholar, an Islamic scholar. So I think that misconception is there. So they want someone to tell them the mental health side of things and also tell them, hey, here are the protection du'as for anxiety and sorrow, because we have that in our tradition as well. So I think that's maybe why they're going there.
Yeah.
I don't have
have anything to add except that I think this is particularly important. Suji mentioned that I work for Heart and have done some work around sexual violence, and I think that erasure around that experience and going to Imams when there has been a harm done is particularly problematic in that way. And that we as, I appreciate so much that we have this space and the Imams are on the other side, but I also think there needs to be some type of integration that's happening, and say that plus, given what I presented in my research, who is not listening to who and why, and what type of woman are we listening to and why, and acknowledging that there is such a thing as internalized sexism. So really challenging us to think about that and who is particularly being harmed the most in these situations. And acknowledging that I also feel very skeptical going to Muslim practitioners sometimes for those reasons. Yes.
Thank you.
Yeah.
Sounds like they can't hear you guys very well in the back, so I can either pass on the mic or you guys can project your voice a little bit, whatever works. There are a few questions here, and in the interest of time, I'll probably have to screen through some of them. People have questions on where can we get the presentations. All our presenters who allowed us, so they have to give us consent for us to publish their materials. If they did give us consent, we already put it on the Huva app, so you can download the app and you will find them up there. The next questions, there are a couple of questions and they're directed towards, particularly towards Lami, so I'll go ahead and put them both together. One, do you recommend the HPV vaccine for teens and preteens? And two, what are the other ways HPV or cervical cancer can be contracted beside intimate relationships?
Okay, so I'm not a medical doctor. Put that out there, right? But what the CDC does recommend that teenagers get the vaccine. The CDC also recommends that both boys and girls get the vaccine. But I can tell you more about the challenges that I have experienced talking to the community about this issue. And it's similar to other ethnic minority populations. We're not unique in this regard. It's also similar to other faith-based communities. Folks are concerned that if they get their teenage girls this vaccine, that it will encourage them to engage in sexual relations and things like that. But the fact is that people are, if you look at the data from Family Youth Institutes, our youth are already engaging in these relations. And it's a difficult piece of data, I think, for people to accept. But when we survey the youth in anonymous surveys and we see that they're already engaging in these behaviors, we need to respond to that. And what we know, again, from more secular or American-based research is that abstinence-only education does not work. That states that use abstinence-only based education have higher rates of teen pregnancy than states who don't. If we teach our youth how to be safe and we let them know what the consequences are and we protect them in all of the ways that we possibly can, we will have better outcomes as a community. And again, I'm not speaking as a medical doctor, but cases of HPV can be spread through oral transmission as well. It can be spread through any type of sexual contact. But what we're finding in the research with Arab Americans in particular is that there is stigma, obviously, against having vaginal intercourse because of the concerns with the hymen being ruptured and things like that. And what ends up happening then is that the youth are engaging in other forms of sexual intimacy and they are contracting HPV in that way. So again, these are ugly truths. It's not anything that anybody wants to think about the community, but this is what's happening and we need to respond to it.
The next one is a combination of questions, and I really like that one, so I'm going to ask. It says, how can we as men be allies in addressing the shame and stigma amongst Muslim women?
That's a good question. Who asked that? Are you gonna give it to me? Oh my god. I took impromptu speech in high school, so I'm like good at it. Who was on speech team? Anybody? Okay. I mean, I always appreciate it when my husband says something. Like, if you see something, say something. Like, if somebody is engaging in body shaming against women, or if someone is engaging in behaviors that exclude women from spaces that men are welcome to say something about it. Like, my husband now is like the biggest rallier against side entrances at mosques, mainly because it was like super inconvenient for us when we had our son, that I had to like go in through the basement and all of that stuff. So whenever he's anywhere, like, he will start saying things about that. And I think that the biggest thing that men can do is to normalize their support of women, and to cite Islamic literature that shows how the Prophet ﷺ treated women. Oftentimes we don't hear stories about Khadija radiallahu anha, and the strong woman that she was, and that other stories are often told to put women in a different sort of place. And so I think that that's one of the biggest things that men can do, is to just, the other side of, if you see something, say something.
Can I add a comment?
Yeah.
Know your religion.
Yeah. Know your religion.
Yeah, I would just like to add to that, and add to the acknowledgement and the validation of feeling, right? So taking sort of like a more gender socialization approach. Men maybe don't always do that work. Maybe it's hard. Maybe you don't want to let go of your power when you invite Muslim women speakers. Maybe you only find them in the last minute. Maybe you don't look at it in a racially representative way. Sometimes just put a little bit more effort into that. So that's one thing. The other thing, I would echo what Lamisa said. I think for me in particular, seeing Muslim women in leadership positions, but seeing a diverse spectrum of that has been really important to me. And again, returning to the tradition around and remembering those traditions when we talk with each other in communal spaces. So one that I really, really like that relates particularly to the research that I do is, Allah subhanahu wa ta'ala does not look at your appearance or your wealth, but your hearts and your actions. And what are we really uplifting, and what are we really validating and affirming in religious spaces around justice, around speaking out, versus some other, maybe it's easier to validate the wealth or the appearance of certain things. So just keeping that in mind, and I don't think that's it doesn't have to be gendered to men only.
From medical point of view, can I add one thing? HPV vaccination should be considered for the men as well, because it's usually the man who carries it and the woman get infected. So we shouldn't even make it only about the woman. It's the screening has to be done in both.
I just want to mention a practical point, something that I've tried with my husband as well in the Toronto community is we'll do like mental health workshops with different organizations, and like there'll be like 100 women there and like 2 men, and that's just how it works many times. So my husband, he was a teacher, now he's a computer programmer, not related to mental health at all, but he's found that when you just get guys to come together and just play basketball or table tennis or soccer, they'll all show up. So now they have this thing at several different mosques. You do half an hour of like emotional mental health talk. They have a different word for it. The men don't say emotional talk. I don't even know what my husband calls it. It's not even, it's a halakha. There you go. He calls it a halakha. It's just a halakha. We're just going to talk about cricket. And then just half an hour, you have to show up for half an hour, 2 hours basketball, pizza and wings after that. So I think that strategy has worked better for men. I want to do that too.
I have a little practical pointer to add to that. So if you're a man and if you're here at the Muslim Women's Panel, you've made the first step. So thank you for doing that. And if you ask this question for a friend or family who do you think needs some help, please bring them to the Muslim Women's Panel on the next conference. Next question is for Alia. What geographical location did your sample come from?
That's a very good question. I have the data, but I don't have it like pulled up quickly. But it was basically a lot of the bigger, like I had asked around East Coast, sort of Southwest. So it was more around states, and so a number of people came from Chicago, East Coast, and then I had like a lot of people, I think, from this area because I went to school here, and then California. So it was a lot of like the Muslim majority, I guess, sort of cities and areas. But what I can do is I can get that data and I can revise my slides, and then I can re-upload it on the Whova app, and then whoever asks this question, maybe by the end of the conference, that'll be up, and then you'll have that data. Thank you.
Also, you can just get a hold of Alia at lunch and ask her, and she'll find it for you. The next one is for you. There are pastoral religious care counseling training programs. Are there those that are Muslim specific or inclusive, if you can talk about that, and also some of the barriers that you think to Imam use in their cause, time, awareness, others?
It's a great question. So the pastoral studies program that I was talking about is at University of Toronto. It's offered through Emmanuel College. It is 95% Christian theology, at least when I took it. This was about 4 years ago. So there was myself and another Muslim girl. All the teachers, supervisors are all Christian, super nice people. But the main barrier was, and they would always tell us that whenever we are giving lecture, we're doing theology, we're doing worship, reflection, counseling, role-playing, all of that stuff, you have to know the Quran and your hadith well enough that you can integrate it. So that was like a big barrier. Thankfully, I had completed like a 2-year course at Al-Huda Institute going through the entire Quran. So I had some knowledge, not enough, of course. But the Christians, like theirs was like, this verse from the Bible is related to this. And it was very, very structured. For us, it was a bit more free flow. We just had to come up with our own reflections and take things from our tradition. Now they have made a call for more Muslims to come, and now as Muslims are graduating from this pastoral counseling program, they are now becoming the supervisors. So alhamdulillah, we have Muslim supervisors who are counseling the trainees in Toronto, so hopefully we can have some sort of a manual for this program.
In the interest of time, I'll just take one more question. But there is someone who wants to know how to move into the mental health field, coming from the master's background. We do have sessions on it on Friday and Saturday, and I would recommend you meet either our presenters here or Dr. Abbasi or Dr. Hamada Hamid, who are both here, and Dr. Halim Naeem. So grab whichever one you can, and I'm sure they can direct you towards that. The last one, I think, is very close to my heart. It says, how do we support religious commitment without supporting guilt or shame in women and girls, also without mischaracterizing Islam? I think it's one of the questions where everyone kind of is scared. Where do we walk the thin line? So if any of you wants to take that.
So I hear that this question is pretty directed at me. And I think I'm going to be honest and kind of vulnerable stand on in terms of indigenous populations and Black Muslims. And so if that's going to happen, that we need to carry everybody there. So I would say maybe, doing the work to develop trust, doing the work to do work that uplifts all types of Muslims. But I do think it's possible to do together. Thank you.